Good morning, good afternoon, good evening, and thank you very much for joining us for the fifth in our series of In Conversation With, part of the Lancet Commission on Gender and Global Health. This evening, we'll be joined by Commissioner Gary Barker and colleagues as we explore a conversation around masculinities and health. You can join us online via our Twitter. Please use the hashtag Lancet Gender or Gender and Health Hub, and you can follow us on Gender and Health Hub and at Gender and Health and Gender and Health Hub. Just a few housekeeping reminders. Please do tell us in the chat your name and where you're from. Add any questions that you have for us in the Q&A box. We'll be tracking them and passing them on to our commissioners. And feel free to express yourself with emojis, but most of all, participate and enjoy today's conversation. So I'm going to quickly pass over to our Commissioner Gary, who will give us a short presentation before introducing the panel with a series of Q&A before we close. So with that, I introduce you to Gary. Over to you.
Thanks, Emma. It's a pleasure to be here and be part of this conversation, joined by quite a few esteemed colleagues who have been inspiring our work at Equimundo about masculinities and health. We deliberately chose a panel to talk about masculinities and health in relational and intersectional perspectives. We know there has been increasing discussion about men's health, and we've deliberately called this masculinities and health to look at the broad social determinants that drive health outcomes for women and men and other non-binary individuals, and particularly to look at how the power structures and inequities that intersect with masculinities drive and affect health outcomes. If you'll start with the first slide, please.
If you can just pause with us 1 minute, our colleagues on Zoom are having a challenge hearing. Just one moment.
Sure, absolutely.
Just testing. Those of us on Zoom, can you hear us now, please? Okay, apologies for that. I'm just going to pass back over to Gary. Gary, over to you.
Great. So I'll start with an introduction and then we'll come back and I'll introduce our three panelists. So if you'll pull up the first slide, please. Great, on to the next one. Thanks. Much of the data about men's health is clearly known and discussed a lot. We know that men face higher rates of premature death, injury, and higher morbidity rates from most chronic diseases compared to women. Suicide is often held up as an example. Men have 3 times the suicide rates compared to women, with huge differences, obviously, by country. As we look at just a very superficial intersectional lens, we know that low-income young men, and those may be from certain historically marginalized ethnic groups in some countries, have the lowest rates of seeking and obtaining health care in most countries. And we know that as we look at the analysis of what ails men, that nearly 50% of premature male deaths and about 70% of male morbidity are related to 4 key risk factors: diet, smoking, alcohol, substance abuse, and occupational hazards. All of those we could talk about for hours in terms of the complex factors behind them that have to do with what food one has access to in terms of income, how corporations market tobacco and alcohol to specific groups of men and sometimes obviously women, the kinds of work available to men, particularly low-income and marginalized men, in terms of what possibilities are available for the kinds of work that they have typically been channeled or socialized, or work that has been made available to them. The next one, please. I show here the cover of an analysis of that research that we carried out with Global Action on Men's Health, and that Movember was also a partner in. Now, after that presentation, that kind of very, very quick presentation of the overall data, and the look at the fact that men's life expectancy on average in the world are about 5 years shorter than women's, the conversation often gets stuck there. One, we often get into a scarcity lens that discussing men's health or masculinities and health will reduce a necessary focus on the unmet and urgent needs of women. We typically there are, of course, in health systems, limited and finite resources, but rather than a relational perspective, we typically get into that conversation that too often is one's needs versus another. We often fail to look as well at how men's health, their premature death and chronic health needs affect the lives of women and girls and vice versa. Men's premature death leads to tremendous impacts on women at the household level in terms of historical patterns of care. We know that it's often women who pick up the pieces when, whether sons or male partners or other men in the household, either face chronic health conditions or premature death. There's a little bit of research on that in the HIV and AIDS field, some in context of high urban violence, and looks at how those affect women who typically pick up the psychological as well as the economic cost when individuals, particularly sons or male partners, die prematurely. There's been very superficial conversations about intersectionality. We typically look at poverty as a key element, but we fail to look at many others, such as displacement, conflict, etc. And then often as we talk about men's health, it's often, as many groups have tried to call attention to it, including us, we often get stuck in these frozen pictures of risk, vulnerability, and harm without recognizing just the dynamic nature of individuals, of households, of communities, and the numerous examples as well of resilience and care. Men acting as activists in the health system for their own care, for their communities, for others, for their households. So I'd also like to call that out. Next slide, please. And then finally, as we step into inviting our three speakers, I think we're also often stuck in a masculinist approach to masculinities and health. And by that I mean as we look at how to respond, many of our campaigns, much of our work, many of the blogs that show up urge men to kind of care for themselves. If men would simply change their individual behaviors, we could fix this all. Rather, that is often the message, rather than looking at how men's lives are shaped by structural, systemic, social forces around them. And so I think this masculine bias often leads us to that we focus on self-care in this era of the self, instead of looking at just all the structural factors that shape men's individual actions that of course matter in the context of health, their own health, the health of their families and their partners. With those limitations and those critiques of some of the discussions of masculinities and health, we've invited three speakers who do think specifically about these broader structural, systemic, and contextual factors. We'll look at Brazil's men's health sector as a key example from the global south of a health systems model. We've got a colleague from Movember who will talk about narrative shift issues, aspirational views of masculinities and health, and a colleague from Georgetown University in the US who looks a lot at health equity, particularly as it intersects related to men of color in the US. So if you bring up the slide of our speakers, I will introduce the three of them and we'll step into that conversation. All right, great. I'm pleased to introduce first Derek Griffin, who is the founding co-director of the Racial Justice Institute and founder and director of the Center for Men's Health Equity at Georgetown University. We'll then hear from Marcos Nascimento. Marcos is a professor at the Instituto Nacional de Saúde da Mulher, which is part of Fiocruz, Brazil's Ministry of Health. And then we'll hear from Sarah Sternberg, who is the social impacts campaign strategist at Movember, the world's largest NGO working on men's health. First off, thanks all three of you for being part of this conversation and for inspiring work that we do at Equimundo. We're thrilled to get to partner with all of you in different ways. So I'm really thrilled to have all of you here. Derek, we'll start off with you. Your work is focused a lot on masculinities and health with men of color in the US and certainly internationally as well. Would love to hear from you within this intersectional lens. What are the key barriers to better health for men of color? What has your research found on that? And what do you think is missing from the conversation?
Well, thanks, Gary. I really appreciate this opportunity. It's been a delight to partner with you over the years with Promundo and now Equimundo. I also should say that I'm the co-chair of Global Action on Men's Health, and so, or vice chair of Global Action on Men's Health. And so a lot of this work that I'll talk about or mention is also in partnership with them. I think the approach that I'll start with is that I found sort of challenging is that we tend to prioritize masculinities and masculinity and gender, that conversation, over other social determinants of health that may have equal or potentially even more implications for and drive the poor health of men, more so than masculinities and gender related factors. So if we think about the ways that, marginalized men or men who are, kind of called subordinated, their identities, whether it's their, racial identity or designation, ethnic identity, sexual orientation, those kinds of factors and how that intersects with this gendered lens that we're using can actually play a bigger role because the structure of our society as it relates to those things that affect their economic status, political factors, and so forth are genuinely shaped as much by those factors as it is by the gender factors as well. So the second part of your question was, what did we find in our work? And so a lot of our work has really tried to talk to men to find out what are their perspectives and thoughts about these types of issues. And one of the things that we found initially was that men don't necessarily equate masculinity or masculinities with the deficit lens and the poor health outcomes that we sort of tend to think about as in the way that we frame these things in public health related conversations. They tend to actually incorporate one of the things that we tend not to do in the way that we talk about masculinities and health. If we're thinking about adult men in particular, adults who are male in particular, that they tend to think about their age in that phase of life and what it means to be adult, in addition to what it means to be a man or presenting as male or living their lives as men, that those factors in combination really do shape how they see the world. And the difference that makes in the focus on manhood versus masculinities becomes an important one because it highlights the character, the types of implications they have for other people in their lives, the ways that they're affecting their communities, the ways that they're being part of building the lives of a family more so than it is about them and their own identity and their own behavior. And ironically, one of the ways that they think about and that we've, in talking to many men, talked about and think about their own health is how it relates to, they tend to prioritize their own physical health and mental health for that matter, less than they do their ability to affect positively others in their lives and so forth. And so those kind of ways of thinking about masculinities tend not to be part of the conversation that we usually have. The third thing that I would say is missing, and you touched on it a little bit in your opening, is the ways that we think about intersectionality. We tend not to sort of think about it with the original nuance and sophistication, in my opinion, that Kimberly Crenshaw did in the early 90s. And when she talked about this idea of intersectionality, she immediately said from the beginning that we should ask the other question in the sense that we should basically look at that. Well, let me start back up. One of the first things that she said when she started talking about intersectionality was that it should disrupt the tendency to see gender and race as separate. The second key part of that is that she argues that it should be expanded to other issues, not limiting it to gender and the focus on Black women, which is where she originally studied this work, that it should also include class, sexual orientation, age, and color, as she wrote in 1991. Then she talks about asking a colleague of hers, Mari Matsuda, who says we should always ask the other question. When we bring up a gender conversation, we should ask, where is race in this issue? And where is racism in this issue? Actually, she said it very explicitly, where is racism in this issue? And she very deliberately did not say, where is race in this issue? Because the structural factor that we're talking about as we talk about gender and masculinities is really racism, not race. And so it's important to make sure that we label that and talk about it from that perspective. She then goes on, Kimberly Crenshaw goes on to talk about intersectionality in 3 different ways. And I'll quickly try to do that as I get to close. She talks about structural intersectionality, which is really about how the factors that combine in a particular population group or individual's experience are qualitatively different from others. And so an example of that would be how Black men are characterized and how that as violent, delinquent, troublemakers, so forth, and how that leads to, you know, the types of deaths and murders that we've seen of George Floyd and others with unarmed Black men and so forth in the United States. She also then talks about political intersectionality, or what are the things that actually renders men or population groups invisible in these conversations. And so part of the challenge of the ways that we've approached masculinities has been that we've rendered basically these population groups like Black men, Latinx men, sexual gender minority men as invisible in these conversations, and have not put them at the center of that conversation, despite the fact that their health is actually what usually is driving the poor numbers for men. The last part is thinking about representational intersectionality and the images that are created and reproduced that basically shape this narrative and conversation around men's health and masculinities. And so in our work, what we've tried to do is bring those kind of things together to really sort of address this issue of trying to operationalize this idea of masculinities through, you know, some of our projects called Mighty Men, some of the ways that we think about how to actually utilize that information and the positive aspects of manhood in tailoring information and creating motivational messages for men to deal with things in their lives so that they can figure out ways to deal with the optimal situations that they live in. And then the other part, just kind of quick example, is the Movember Rooted and Rising program, where we tried to really help young Black men who are digital creatives who are 18 to 25, basically create content that would incorporate social self-care and focus on well-being into their art, and then have that actually be something that is protective for them, but also is something that is helpful to their audience as a tool to disseminate that throughout the community. So those are the kinds of things that we're finding in our work thus far. Thanks.
Great. Thanks, Derek. And I think in particular, thank you for reminding us of the asking the other question. And I truly appreciate your comments on going deeper in the implications of an intersectional lens, so that it's not just we tag it on at the end, but really to see the other structural forces of inequality, particularly racism, in other contexts of the world. We could add other isms that fit in that, but clearly that's the lens we need to take into it. So thanks for that, and I'll come back in a little bit with another question. Let's go now to Marcos Nascimento. Just giving a second for Marcos to get on screen. Hey, Marcos. Marcos, you've been involved in advising on the creation of and the evaluation of Brazil's men's health program and its incorporation into the Ministry of Health. That's been a lot of what you've researched. Tell us about how it has worked, what has worked, lessons learned, things that haven't worked.
Well, first of all, thank you, Gary, for the invitation to be part of this panel. As Gary said, I've been involved since the very beginning of the men's health program here in Brazil. The program was launched in 2009, so over 10 years, more or less. And since then, it was not fully implemented in the country. We need to highlight that we live in a very large country with very social disparities among different regions. If you're talking about the Amazonic region, it's completely different from the urban areas, such as Rio de Janeiro or São Paulo. But the men's health program is developed by 5 main areas: the chronic diseases, sexual and reproductive health, access to services and use of it. One of the major topics that we need to mention is violence as an external cause for male death in Brazil, particularly young man death in Brazil, and fatherhood and care. I've been very involved in this specific topic, the fatherhood and care, because of my work at Fiocruz, the women's health program that we have at Fernandes Figueira Institute. And with other colleagues from different universities, we are trying to analyze efforts in the whole country about the prenatal care. The prenatal care, male prenatal care, was launched in 2017, 5 years ago. And it's an attempt to engage men and the health sector more broadly. We see that fatherhood is a good entry point to bring men to the health services, not as a sickness or something like that, but in a very important moment for men's lives. And because of that, men have access to rapid tests like HIV and syphilis. This is very important in terms of prenatal care, but also make the companion law works in Brazil. Now, we have a companion law since 2005, but it's not fully implemented in the whole country. And try to engage men not only in this moment of childbirth, but the whole pregnancy. Pay attention not only about the pregnancy per se, but also in terms of engaging them in sexual reproductive health, immunization. It's a very important topic since the COVID-19 2 years ago, and obviously, the child care. In terms of challenging, there are so many challenges, I think so. Well, first of all, the creation of the men's health program, it was top-down policy. Now, at that time, we brought together academics, social movement, medical associations, and policymakers. But it was something that not emerged from the ground. And I think it makes a difference when you compare with the women's health program or LGBT or Black population in Brazil. Also, as I said, we are one of the few countries with the specific men's health program at the policy level, but we are talking about a country with more than 5,000 municipalities, with different regions, different social and cultural contexts, that makes this full implementation very challenging. We still need to sensitize health professionals about men and masculinities and health. For most of them, makes sense to work with women and children, but man is a strange character in terms of the health scenario for most of them. And for sure, I think in terms of our national health system here in Brazil, the community health workers has a very important role. They engage men from the communities. They engage the population in general, but particularly in terms of engaging men, they have a very specific, very important role, because they go where the men are. And I think this is one of the lessons learned. Waiting for men go to the health clinics is not a good strategy. It's important. We have different campaigns trying to engage them, but go to where women are, I think, is one of the most important lessons that we learned over last 10 years. And for sure, we are living in a very specific moment of our history here in Brazil. Because of COVID-19, we have more than 700,000 people died because of COVID-19 in Brazil. We live in a very conservative moment of our history. So, and we can talk this a little bit later, but I think this lack of sex education, for example, in schools affected all people in general, but particularly young men and young women. And I think it's important to mention that. And obviously, we live in a anti-gender offensive here in Brazil, not only in Brazil, in other countries in Latin America as well, and other countries in Europe. But here it makes a difference in terms of the public health policies here. So thank you, and we'll talk a little bit more.
Thank you, Marcos. And I think, first off, thanks for the reminders around, fatherhood as a point of entry, so that we think about health not just as disease or morbidity and mortality prevention, but also thinking about health as well-being. Your reminder as well of, in the health system in Brazil, how that bringing men in as both their own health, but also in relational perspective to children, female partners, and also your important comment about health providers, that it's not just about trying to get men in the door, but who is it that receives and how is it that they receive men? And thanks as well of just how many countries, well, Brazil and others, where even to have conversations about gender and about masculinities have become politically fraught, polarized, and the space of lots of dispute. So yeah, thanks for that sobering reminder. We'll now go to our third panelist. If we can bring up Sarah. Just to say, Sarah, thrilled to have you here. Movember is the largest men's health campaign and initiative in the world. And I think it's really been a disruptor, and I mean that in the positive sense of getting just creative, thoughtful discussions of how do we think about men's health in broader ways. And I would love to hear you comment on, as you lead some of that work with your colleagues, tell us how Movember has sought to change cultural norms around men's health, how you do that, what works, challenges, and then, I would appreciate your reflections on that.
Thanks so much, Gary. And thank you for having me as part of this conversation. It's, as ever, so rich. I've been making a gazillion notes already. I'll start maybe by just giving a very quick potted history of Movember, just in case people don't know it, because it is a sort of a funny organisation in that it began as a fundraising campaign. It was a couple of mates getting together at a pub in Australia sort of 15 years ago and having a conversation about, wouldn't it be funny if we brought back the moustache and raised some money for charity off the back of it. Cut to now, Movember is an organisation that has raised over $500 million for men's health and has an array of kind of programmatic activity around mental health, men's mental health, also around testicular cancer and prostate cancer, and is increasingly sort of thinking about how to move into disrupting, using some work on disruptive DNA and thinking about health systems more broadly, as well as the settings where men are. But I think it's useful to reflect on the beginning of Movember, because it began really at its heart with a cultural idea, with a sort of, how can we get people to do something, to grow a moustache and talk about health, and use the moustache as a bit of a symbol and entry point to start talking about health. And how can we do that in a way that is sort of really catches on, kind of captures people's imagination. And I think it's telling, because it sort of suggests that Movember has always been an organisation that is rooted in culture, and also how to engage men in ways that feel fun and something you want to talk about, and that sort of start to dispel, I think, notions of health particularly being boring or feeling irrelevant. So with that in mind, I guess Movember has always taken a sort of human-centered design approach to centering men's lived experience. We've already heard, I think Derek put it really clearly, that a lot of the debate around masculinity, language around masculinity, doesn't necessarily resonate with men, and actually also neither do ideas about health, because of some of the sort of barriers he mentioned around men being, more motivated by caregiving and sort of thinking about others potentially than themselves. Also, some of the norms we know about around stoicism, norms around recklessness. Neither of those things are going to kind of help men think about health. So our goal really is about trying to contextualize these things and make them more appealing, make them feel like they're part of life, as one of my colleagues always says, rather than that they are health. And we tend to take a life cycle approach. It was really interesting hearing Marcos talk about the work that they've been doing in prenatal care, because we also try and pinpoint some of those moments where men might be thinking about masculinity differently. And fatherhood is a really key juncture for that. It's a transitionary moment in one's life. It's a moment where a man is likely to really be reconsidering his own identity, but also thinking about his own relationship with his father, how things might have changed. And I think we see that as a real opportunity to tap into a moment of change that's already occurring in a man's life, and to encourage him at that moment in time to think differently about how he wants to behave, the kind of father he wants to be, what things he might want to pass on to his son or his daughter. And that can be a really kind of fruitful moment for intervention. Another sort of aspect of our work that, again, Marcus sort of alluded to when he was talking about going to where men are and where women are, is around the key settings where we can reach men. So a lot of Movember's work has historically focused on sport, and sport is a really kind of fruitful entry point for interventions. We run a program called Ahead of the Game, which is all around teaching kind of mental fitness and mental resilience in young men, so sort of teenage boys, and that's delivered through athletes and through schools and kind of sports settings. And you'll notice that I didn't say it's about mental health, and I didn't say it's about mental illness. I said it was about mental fitness and mental resilience. And that's another sort of key aspect, I suppose, of the Movember approach, which is to say, knowing that these concepts around masculinity, around health, aren't necessarily the most appealing thing, rather than sort of, trying to fit a square peg in a round hole, would be much better off actually finding concepts that do resonate with men. And certainly sport as a setting and the idea of fitness and the idea of resilience are things that we found through our research and through our programs to be really appealing. So that's, I suppose, hopefully a useful kind of evocation of sort of how Movember's always delivered work that's felt rooted in culture, whether that's through fundraising as we initially started, or now kind of through our array of programs. It's been an approach that we think served us really well.
Thanks, Sarah. And I think, you several key words that I'll pull out of there that I think connect up a lot with both what Marcus and Derek said. The life cycle approach. So how we look at, age and developmental stage in life, I think, maybe becomes that additional question to let's ask the other question of, how let's not assume that, as we say men or men's health, that we're talking about a 42-year-old who's at risk of a certain thing, but to look really across that age cycle, I think is fantastic. And your emphasis on the positive and on resilience. I think we, kind of underestimate just how much that is a key driver, both to the success of getting men to get the care they need, and to support providers to getting men the care they need, bringing in sports and thinking about youth culture. I think all of those are, in a lot of our top-down, and Marcus mentioned too often as initiatives come from ministries of health, too often they're sort of top-down and let us see if we can make men fit into systems rather than make the systems fit to men. And the same obviously holds in different but important ways for women and non-binary individuals. So thank you for that. And we'll come back with another comment later. Derek, I want to turn back to you and ask a question about health policies. Marcos talked about a policy that came down from Brazil's Ministry of Health and challenges and successes with that one. You've done a lot of thinking about this as well and advocating in the US on it, and talked about the lack of a men's health policy. Would love just in a couple of minutes, tell us what you think needs to be in place in terms of a men's health policy and where we are to make it a policy issue within health systems.
Yeah, so this is actually a quite exciting area that we're finding, again, more in my role with Global Action on Men's Health. And we actually just did a very successful webinar with the Pan American Health Organization, where they launched their Caribbean Men's Health Report, where there's a lot of interest in focusing on men's health, again, bringing in a lot of the perspectives that both Sarah and Marcos mentioned, where we're thinking about more of a strengths-based approach. Let me also just back up and say, Ireland was the first country that actually had a men's health report, and then I believe was followed by Australia, Brazil, and then Iran, ironically. And then there's been 3 others that I know of, and that is Malaysia, Mongolia, and South Africa. So, and then when we did the work with PAHO and Global Action, there were some other countries that expressed interest in developing these. And so there is this trajectory of starting to recognize the importance of men's health, if for no other reason, frankly, because men's health tends to be a drain on the economies and the health resources of a lot of our countries. Yep. And so I think one of the strengths of these approaches is doing, again, a lot of what Marcos and Sarah have said, of taking a life course perspective, building in a strengths-based approach. We haven't used the word gender mainstreaming in this conversation quite yet, but this idea of looking at policies and practices through a gender lens and how that is differentially affecting people of different genders. How do we think about other social determinants of health as they intersect with gender, as things that we need to deal with and incorporate into our lens of how we approach these issues, are all things that are now being brought into a lot of these policies. And some of that's been pioneered by Brazil and other countries, but it's also thinking about how do we continue to advance this kind of work and look at things from both a positive perspective in terms of what are the things. You're not going to usually get people to do things if you only see them as negative and you only focus on the negatives of them. And so this idea of being able to build on the strengths and do that and have messaging and campaigns that are going to be positive in nature, yet deal with the heart of what we need to deal with, that's quite the dance and the balance, but nonetheless necessary.
Thanks for that, Derek. And I'll just pick up on one comment you made about Ireland being the first country that has had a men's health policy. There's a NGO network called the Men's Development Network in Ireland that has been at it for 25 years and was, as I understand, has been a key voice in articulating that health policy in Ireland. And also, I should call it, has been really important about looking at the linkages between gender equality and men's roles as allies in achieving equality for women, and particularly their work around ending men's violence against women and looking at the linkages there. And I think that gender relational lens, is a lot that I think we can learn about how we can articulate men's health sectors that are done in partnership with women's rights organizations and with a lens toward gender equality as well. So thanks for those examples. Marcos, want to turn to you now. You mentioned as kind of perhaps the success story within Brazil's men's health program being around fatherhood and men's care. Mm-hmm. We know that typically limits in the context of heterosexual households or heterosexual couples. But would love to hear you tell us particularly ways that the men's health program has also sought to look beyond the gender binary. So whether we look at men who have sex with men, gay men, non-binary and trans men, how is the health sector built, particularly on Brazil's important work in the HIV space that's looked at the complexities of sexual orientation and gender identity?
Mm-hmm. Thanks, Gary. You mentioned at the very first beginning of our session about intersectionality and social class, gender, and other factors important in terms of thinking about masculinities and health, their structural racism, and I would add this to other social markers like sexual orientation and gender identity as well, in terms of thinking about not only with the men who are heterosexual, but all possibilities and diversities in terms of being a man. Or I think in terms of Brazil right now, as I said, well, we are dealing with this gender ideology notion, we're a lack of sex education, lack of educational campaigns targeted to HIV, for example, here. We were one of the most famous programs in the beginning of the epidemic of HIV in the world because of our communication strategy, and also other factors. But nowadays, we do not have any kind of this here in Brazil. For sure, we have the men's health program, and we also have LGBT health program and Black population health program as well. One of the challenges to make them dialogue. No, it's not a separate boxes, but we need to take into account the intersectionality in terms of bring all these aspects together. There are some few initiatives here in Rio de Janeiro, in other places in the country, but it's still a challenging and how to make this different policies, dialogues for better outcomes in health, I would say that. And particularly in a very conservative moment, we see the importance of the social movement. The civil society organizations have a strong role in terms of pushing this agenda. So Black population movement, LGBTQIA+ plus movement, all of them has a very important role, including the women's movement. And I think from my perspective, men and groups of men that are spreading all over the country has also a very important role in terms of discussion about homophobia, about racism, classism, sexism in the country. So it's not easy, but there are some good examples, few initiatives on that. We are not listening to you, Gary. Your mic.
Yes, I put myself on mute. Thank you. It had to happen sometime. Thanks for reminding us of just how do we break those sectorial boxes that come up, both in health sectors, but also our research and civil society organizations. And I think, you also hint at, just how much civil society voices have been important forces to try to keep, with all the political challenges in Brazil at the moment, with a right-wing anti-gender lens government, keeping the importance of whether it's LGBTI plus groups or others groups that you also mentioned as well, keeping the pressure on the Ministry of Health to keep services as they should be, or to call attention to the gaps, et cetera. So thanks for that. Sarah, back to you with a question around, you talked about some of the things that have been working and where Movember came from, your use of sports, engaging young men, engaging celebrities. But I'd also like to ask you about some of the resistance to Movember's work. What have been some of the challenges in terms of take up, and how have you avoided resistance or encountered it? If you can bring Sarah up.
Thanks, Gary. This is such an interesting question, and I think sort of does hark back to a point I made before around a lot of the research that we've done, particularly with young men, in fact, reveals that the sort of gender debates, ideas around, gender identity that feel very big in academic circles, and also feel very big in kind of, media-driven culture wars, really don't, as far as we've understood it, seem to resonate with young men. And if anything, they feel like there's a sort of binary that's being, or polarity that's being created that doesn't reflect their own experience. I remember particularly doing some research where a 14-year-old boy in the UK said, I'm still at school, who am I going to talk to about this stuff? My teachers, my mum. It was just a real sort of eye-opener of, we're maybe existing in a certain social space where there's fluency around these things, and that's just not the case kind of more broadly. But I think one of the sort of techniques that we've really capitalized on at Movember to avoid resistance, to avoid kind of falling into some of those traps, has also been around framing, and really working very hard to use the language that men themselves use. So, for example, a piece of work that we've recently completed in the UK, which is aimed at teenage boys, we're encouraging young men to check in with a friend, sort of check and sort of seek support when they need it. We came to call the sort of program "Come Check Me" because that was the language that, when we did a co-creation workshop with young men, they used. And I would never have come up with that, and nor would any of my colleagues, because we simply don't exist in their sort of social world. But by getting what might be something that young men would traditionally resist to, which is effectively mental health messaging and programming, getting that to be framed and presented to them in a way that is speaking their language and speaks to some of their existing behaviours, has meant that the programme has sort of managed to be a huge success, both with engaging young men and then actually driving them forward to seek support. So I think that's been the sort of our sort of tried and tested, I suppose, techniques for managing that resistance, is really to try and situate ourselves in the lived realities of young men. And in fact, the programme Derek spoke about earlier, Rooted and Rising, which is about working with young Black male creators in the US, that was hugely grounded in research, was working within a community and using the voices of that community to champion change. And so, yeah, if there's one thing I would sort of say is the Movember way of generating programs that work and of managing some of that resistance, it is to be sort of really attuned to the lived realities of our audiences.
Yeah, thanks, Sarah. And I appreciate those reflections. And I think we often, as we look at a disease focus or a human-centered focus, I think we get different approaches. So thanks for sharing that example of a kind of listening to lived realities and framing the discussion from there. As Marcos mentioned earlier, of Brazil's men's health sector, although it's had lots of input from civil society, but still sort of coming from a top down. And I think the obvious lesson learned from the examples of all three of you, of just the living in, understanding, listening to lived experiences, the complexity of those, asking the multiple questions, looking at how they're embedded both in gender, racism, and other intersectional related topics, leads to what feels to be better approaches. And then the question, of course, around better outcomes. We've got a few minutes for questions, and I'll just bring one of the first ones while anyone else who is in the audience wants to ask one. There's an important question about what recommendations you would offer around changing societal and cultural expectations regarding men of color who are gay or are men who have sex with men, or pansexual or transsexual, in terms of their health needs, how to get the health system to respond, as well as to think of cultural shifts that need to happen. And if there's if there are any other questions as well, sorry, if you guys would like to comment on that. Sorry, I'm just now looking at the other ones that have come in here. So I'll open up to, I'll try to chew gum and walk at the same time. But first put that question there, and any of the three of you who would like to jump in, and I will quickly read some of the other ones that are here.
I'm happy to start. I think for that question, my first reaction is it seems like the challenges that we're describing are really not with the population who essentially has the issue. It's the system that has basically, in our society, that hasn't accepted that they are who they are, and that just, we're trying to, so we need to put our energy into changing the system, not changing the men who we're talking about, first of all. I think making the system more trustworthy and for the system to demonstrate that it actually can serve and effectively serve that population, and that is open and receptive to that. I think Marcos gave some good examples of how their system has not necessarily been open to those spaces, and that work needs to continue. So I think that for me is the starting point.
Thanks. Marcos, anything you'd like to add about that?
Well, as I said previously, I think, and I totally agree with Derek in terms of thinking about the system that make it happen. But at the same time, it could be interesting that when we are talking about health needs, to bring together other players to this field, education sector, it's quite important. The social development sector, thinking about workplaces. I mean, so there are several other players that are so important that make a difference in terms of health needs and health demands.
Great, thanks. Sarah, do you want to comment on that, or okay, No problem. Couple of questions here that I'd like to. Well, I'm looking at time here, but I think we'll try quickly. And one is around external causes, so accidents, suicide, violence. Marcus, you touched on this. I think Derek, you did as well. Any comments you'd like to say there on, the approaches necessary, strategies necessary, any nuances as we often look just at those sort of numbers and compare men to women? Any reflections you'd like to offer, the two of you, and then I'll come back with a question for Sarah.
I'm glad to start. As I said, well, in the case of Brazil, we have high levels of traffic accidents and violence. It's the external causes that provokes death in the male population, much more than any disease, any other factors. And for that, I think it's not only social class is an important part. Poverty, less of opportunities, etc., etc., etc. But I think we also need to bring masculinity per se. So why violence is a male strategy, to deal with conflicts, for example. And I think it's beyond social class or cultural context. Obviously, you have to take into account, but to think about the relationship between violence and masculinities, it's also an important topic.
Thanks. Derek, anything you'd like to add on that?
Yeah, I mean, the only quick things I'll add is that, I would think, as I understand it, sort of road traffic accidents, and particularly in the countries where they're particularly high, and it's one of the top causes of death for men, that there's not a lot of infrastructure, public health and other, transportation infrastructure, and that you see a lot of that, or you don't see a lot of enforcement of traffic laws and so forth. So while gender is a part of that conversation, I think we also have to look at the larger infrastructure and how that's shaping those kind of conversations. The violence, and I want to separate that from the suicide conversation, also seems to be something very much rooted in the economic opportunities and the failed economic opportunities for men in those spaces, and just the opportunities to have, a quality of life that they think can be they're allowed to sort of have, and through an economic sort of, being able to provide for themselves, contribute financially to a household and so forth. Suicide is a completely different issue for me, because I don't know that we understand. I'm not going to pretend like I understand it very well. So I think we've tended to look at it through a lens of depression. I don't think we've looked at gendered depression in the way that we could, in the types of male type symptoms of depression that we've tended to see in other contexts. But I don't know that we have a good understanding. My understanding is that suicide is not something that we know how to predict very well. We don't know how to really identify who's actually at risk for engaging in such behaviors beyond a certain point. And so I think I would just say that we really need to better understand that. Of course, the researcher in me is going to always say more research is needed, but I'll just leave it there. Thanks.
Yeah, thanks for that. Want to pivot to a question and start with Sarah, and then if Derek, Marcos, you have comments as well. We've got a question around cancer follows heart disease as the second leading cause of death among men in the US, and that's also the case in some other countries as well. How do you think about men and cancer? Movember, of course, came on that topic. That's where you emerged from. So any reflections you have on that journey? And Derek, I know that you also work on these issues at Georgetown. So if the two of you have any comments on that.
Absolutely. And I think actually there's probably a link with some of the conversation we've had already in terms of men's help-seeking behaviour, that we know that so much of cancer, so many deaths from cancer would be avoided, or people would have longer life and higher quality of life if they sought care earlier on in the journey. And that often comes down to being able to understand that something's wrong and having the kind of bravery and courage to have a conversation with a health professional about it. And both of those things are in conflict with, or aren't supported by some of the masculine norms, particularly norms around stoicism, norms around not kind of taking care of yourself, norms about not admitting vulnerability. So I think the cancer piece particularly, and there are of course environmental factors, and I wouldn't pretend to be a sort of medical expert on cancer at all, but I suppose in terms of the gendered nature of why cancer is a leading cause of death, that would be sort of the lack of early diagnosis brought about by men not seeking help early enough is something that I would point to. I would also, and I'd be really interested to hear Derek's perceptions of this as well, I would point to the way in which, and this has come up a little bit in this conversation, the way in which health systems are not being designed with men in mind. So I was on a call with a colleague earlier, a cancer specialist, who was talking about how one of the outcomes of the pandemic and of telehealth kind of rising in prominence is that often conversations about concerns men might have about prostate cancer, for example, they're the last thing that would come in a conversation with your doctor if you saw them face to face. And if you're in a telehealth context, time's up. You haven't had the chance. You haven't had the sort of moment with someone in the room to be able to say, actually, I'm a bit concerned about this. And so she was saying they're missing so many early diagnosis opportunities, particularly in prostate cancer, because of the fact that what men might need in order to not only seek treatment, but also then have successful treatment, are not being designed into the health system currently. Great,
thanks. Derek, I don't know if you have anything you'd like to add very quickly. I wanted to touch on one final comment, and then I'm very conscious of time, so I'll begin to close. Anything you'd like to add quickly to that?
Just very quickly, the reason, so I would say that we need to look at heart disease and cancer together as opposed to looking at them separately, and recognize that both of those, the reason they're leading cause of death is because they're leading cause of death for men 45 and older. So we need to look at what is it about middle age and older adulthood and what's happened over the life course that puts them at risk for both of those.
Great, thank you for that, and succinct. Marcos, if you've got time to comment on a last question, which I think is a key one, and maybe we will close on that, which is, we've got a question about strategies for engaging men in prenatal care that pay equal attention to supporting women's decision-making over their own sexual and reproductive health and bodily autonomy. And I think that is a key issue as we talk about masculinities and health, is to say this is not, we've got to figure out a way that we both in health service practice, we do not do this at the expense of women. And that as we talk about it politically and our advocacy work and our research, that this is not about pitting men's needs over the needs of women and other individuals. If I would like to give you a last comment on that, and then we're going to close out.
No, for sure. No, I think we need to think about gender equality. No, that means bring together all perspectives involved. And I think in terms of our experience here in Brazil, we are just starting that at the policy level. We have a long way to walk.
Great. I had prepared a couple of conclusions, but I think you all just summed it up extremely well. And I want to be respectful of folks' time. I know you've got to shift to other things, but I really think this deeper intersectional lens, Derek, thank you for bringing that up. Sarah, thank you for bringing up both like, how do we look at the gendered norms around this, do this from men's lived experience, do it in ways that build on resilience and hope and positive aspects of men's lives, I think really clear. And Marcos, the experience of, how to navigate this in a huge, complex system, live through the political challenges when, talking about gender is not even considered okay anymore. And to think about that in the relational perspective that you brought up, both particularly around fatherhood, and that is a part of port of entry, I think all key ones. So I, don't have time to go through all these conclusions here, but really, I think that's where we want to end, is to acknowledge that we do need to bring this relational, intersectional, and using Sarah's words, this life cycle approach is, we think, the way forward. And for the Lancet Commission on Gender and Health, we do hope to come out with some recommendations and ideas, and we'll be including some case studies and data that the three of you have all been key in developing. So thank you for your time. Thanks all for who were able to join us. And you can look on the Lancet Gender and Health Hub. We will post this recording and other resources available along the way as well. So yeah, thanks all. Have a fantastic rest of the day and evening, depending on where you are. And thanks, Emma, for and Tiffany for all your support in the session itself. Thanks much. Emma, I'm not hearing you. I know there may be some sound issues, so but I'll just say we're closed, and there's some previous episodes, and look at the website for future ones. So with that, we'll sign off. Apologies for any who had challenges on some hearing us. We had some technical difficulties, and we appreciate your patience. All the best. Thanks very much.